Hey, hi guys, Dr. Dan Nightingale here, your clinical dementia specialist. I hope wherever you are in the world, you're having a good day, a good evening, a good week. I certainly am. We've got some good weather here, or some people might say it's bad weather because it's very hot. But people living in the heat need to maintain a high level of hydration. Don't forget, drink plenty of water. Okay, today we're going to do the Q&A session that I talked about last week. We've got some questions that have been submitted by our followers, and I'm joined here with Lynn. Hi, Lynn.
Hello.
And she's got the questions, and the people who asked them, she's going to tell me what they are. So, here we go.
I wonder what the common early signs of dementia are, and at what point does cognitive degeneration have to reach before an accurate diagnosis can be made?
Okay, and who asked that one?
Dean.
Okay, thank you, Dean, for that question. So there are three key things to look out for, and this is with the most common type of dementia, which is Alzheimer's disease, which affects around about 80% of all dementias is Alzheimer's disease. The three things that I recommend people look out for, first of all, is immediate memory challenges. So things like forgetting what you had for your breakfast this morning, forgetting that yesterday you went to see a relative. So immediate working memory, short-term memory challenges, issues. That on its own does not mean there is a dementia type illness going on. There could be something else. So we look for two other things that accompany that. And one of them is disorientation in time and space. So if I asked Lynn, what time is it approximately, without looking at a watch or a clock, she will be able to tell me it's around about, 5:15, 5:30. If I ask that question to somebody who is experiencing dementia, they may say it's 3 o'clock in the morning. So the challenge is with time, so disorientation in time and place, not being able to find your way. So if you live in a house and you've lived in this house for 30 years and you know how to get from your kitchen to your bathroom, suddenly you're challenged with that. You're not too sure how to get to the bathroom, which room is the bathroom. So that's the second thing we look for. And then the third thing is being able to follow a common procedure, something that you've done for many years of your life. For example, fastening your shoelaces, or baking a cake and following a simple recipe to bake a cake. And instead of using sugar, you use salt or something like that. So those are three things that would indicate that there's something going on in terms of a cognitive shift, a cognitive change, a memory issue. And it is at that point that I would then suggest you go and see your GP, your primary physician, get a bit of an evaluation, a cognitive evaluation, and then a referral on to whoever it may be. Different countries have different procedures. So in the UK, you would be referred to the memory clinic. In the US, you'd be referred to a neurologist specializing in dementia or neurocognitive disorders. The ending of that question related to...
At what point does cognitive degeneration have to reach before an accurate diagnosis can be made?
Today, we are so good at being able to diagnose as long as we use all the battery of tests. And all the battery of tests include a neuropsychological test, involve an MRI, involve possibly a spinal tap. We've got a really good blood test now where the blood test will indicate and show you the proteins that we're looking for in Alzheimer's disease. So there's lots of other battery of tests. The sooner the diagnosis, the better, because as soon as you get diagnosed, the treatment and therapy begins. So thanks for asking that, Dean. Appreciate it.
Okay. Sharon says, is it advisable to inform someone living with dementia that their close relative has died?
Thank you, Sharon, for that question. That's a very complex issue, isn't it? That's a very individualized situation that happens. My approach is this. Everybody has the right to know that a member of their family has passed. Whoever it is, son, daughter, mother, father, husband, whoever. We only need to say that once, maybe twice, just as we would do with anybody else, people who don't have dementia. We would tell them, and then you deal with what happens afterwards. If after a certain length of time the person asks, where is my sister, where is my mother, when are they coming, then it's at that point that we don't say, oh, they died last week or 2 weeks ago. Instead, we engage them in a conversation about that person. So the common example that I give is somebody saying, when is my mother coming? And I'm not going to tell you that your mother's died. Instead, I'm going to say, what's your mother's name? What do you do when you hang out with each other? Where do you go? What kind of things do you do? And then involve them in that conversation. And if they say something that resonates, like we like to watch a movie, then, hey, how about we go and watch that movie, your favourite movie that you like watching with your mother or your sister or your brother or whoever it might be. What we're doing there is validating the person's belief. We're validating where they are at that moment in time. And as I've said so many times before, we need to meet the person where they are at that time. So that's how we would do that. Everybody has a right to know. We would tell them once. We would deal with the situation just like we would with anybody else. And of course, loss and bereavement is a roller coaster of emotions. So you don't have to have dementia not to take in that information immediately. Sometimes it does take a while for that to sink in. So that's how I would deal with that one. So thanks for asking that, Sharon.
So how is that validating? What do you mean when you say validating? Because I understand you're saying you don't want to use language like, remember, I already told you. What do you mean? You know that they were sick. You know they weren't doing well. I'd already told you. So what is this, when you say validate, explain how, what does that mean?
So what we're doing is validating that person's belief system, okay? We're not going to say, well, she's died. She died last week. She died 2 weeks ago. She died last year. We're not going to do that, because each time we do that, that's new news to somebody who's living with an immediate memory issue, okay? So instead, where that person is and what that person believes is what we validate. So that's why I would ask, what is your mum's name? Well, my mum's name is Elsa. So, okay. What do you do when you're hanging out with your mum? And we get into that conversation about those things. So that's where my validation comes in. I'm validating where you are right now, because where you are right now is feeling frightened, feeling vulnerable, feeling anxious, because I'm looking behind the meaning of what you're actually saying to me. When you say, I want my mum, what am I actually saying? When I want my mum for a particular reason, because I'm feeling afraid, because I'm feeling anxious, because I'm feeling worried. And so you validate that feeling, you validate that emotion. You can probably hear my dog snoring, I don't know.
Big time.
He's very tired today. So that's what I mean by that, Lynn. But thank you for asking that. That's needed clarification. Thank you.
Okay. Diane says, how can the caregiver help to curb anger directed at them?
That's a really good question, Diane. Thank you for asking that. The issue with that is the closest person is usually the one that gets the grief. The closest person is usually the one that is the baddie. And
Closest person to who?
to the person who is living with dementia. So you might be the best person because there might be 3 members of the family, three siblings. 2 of them might live in a different state or in a different country or a different part of the country. And they don't really see that person very often and they're not too much involved. And yet they are the bee's knees. They're wonderful, they're beautiful, they're great people. But you're the one who's delivering the care, you're the one who's the closest person, so you are the one that unfortunately is at the end of an individual's frustration, agitation, aggression, whether that be verbal, physical, or what that may be.
Or justified or not.
Or justified or not. So what you need to do is do you. Make sure that you look after yourself, number one. Secondly, when that person does start to present with an aggressive form of behaviour, you follow my 5-minute rule. And my 5-minute rule is that you say, look, I can see you feeling frustrated or angry right now. I'm going to remove myself. And then in 5 minutes, I will come back and see if we've both calmed down by this time. So don't proportion blame, don't judge, just take care of self and remove self from the situation. And then return after 5 minutes. Make it 5 minutes, not 6 or 4 or 10, 5 minutes exactly, return and see where you both are at that time. Has the person calmed down? Has the person forgotten what the issue was and moved on? How are you feeling right now? Have you been able to go outside, take a breath, find yourself, center yourself, ground yourself, and then go back to supporting that individual? If that hasn't worked, repeat. Withdraw, 5 minutes, same procedure, same thing, and go back. And you will find that as you do that more often, as a process, that works more and more. It becomes very effective. So that's what I would suggest for that. Don't take anything personally. Don't take it as a form of insult.
Attack.
Or attack, because you're doing a good job. You're supporting that individual. You're there. You're doing it. You're supporting the person. And you're always doing a good job. Everybody out there, and I think last week I sent a massive thank you to everybody who is supporting somebody to live with dementia, because it's what you're doing that is helping them. It's what you are doing that is maintaining a level of quality of life for that person. It's what you're doing that is slowing down the progression of the disease. So remind yourself, I'm doing a great job. Give yourself a pat on the back and don't allow your self-confidence or your self-esteem to drop. Just remind yourself, this is hard, this is a journey, there are good times, there are not so good times, and you are doing an absolutely fantastic job. Okay, and thank you for asking that question.
And a follow-up to that would be, a question I have is it okay to set boundaries with a person living with dementia that you're supporting?
Funnily enough, I had that very question from a patient yesterday.
Oh.
Well, a patient's relative. Yes, it is.
It's not cruel?
No, there has to be boundaries. There has to be ground rules. Just because somebody is living with a cognitive change does not mean they can do whatever they like and get away with it. It's not right. It's not acceptable. What we do is understand that the behaviour is triggered by the disease. We understand that, we get that. However, there has to be the ground rules and there has to be boundaries. And once the person crosses that boundary, then that's where all the conflict begins, isn't it? That's where it starts. There's a conflict. So if these boundaries are clear and precise and consistent, I have these 3 C's: communicate clearly and consistently. Everything has to be consistent, and everybody has to use the same approach, the same language, and the boundaries and the boundaries and the ground rules have to be the same for everybody in that dynamic. So if it's 3 siblings looking after mum, then the language, the communication, the boundaries and the ground rules have to be the same from everybody. Consistency is key. So that was a really good question there, Lynn, because I did get that yesterday.
Okay. All right. There's another question from Karen. Does dementia affect everyone the same way?
Okay, so thank you for asking that, Karen. That's a good question. No, is the short answer. Dementia impacts people in different ways. The symptoms are going to be the same. The process, the neurocognitive process is going to be the same. However, it does impact people differently. Everybody's individual. Dementia is as individual as your earlobe or as a fingerprint. Okay, it's totally individual, and the journey is different. So if there are 10 people in a room and all 10 people are diagnosed with Alzheimer's disease at the very same time, everybody will deal with it differently. Everybody will progress differently. Depends on your age, depends on your circumstance, depends on your education, depends on your family dynamics. It depends on many, many contributing factors that feed into how that dementia impacts the individual. So great question, Karen. Thank you for asking that. And I hope that addresses that.
Okay. Last question. Had today, speaking to someone on the phone, they wanted to know if a diagnosis, how important is a diagnosis? Because one neurologist told her family that it doesn't really matter what the diagnosis is because we're going to treat the person the same way we would others. So how important is a diagnosis, and what do you feel when you hear that statement?
Yeah.
Because I got angry.
A diagnosis is absolutely crucial. It's crucial that you have the correct diagnosis. I mean, let's think about this. If you have a diagnosis of cervical cancer, but you've really got breast cancer, how is that? You know, how does that work? So saying to somebody, well, it doesn't matter about the diagnosis because we're going to treat you the same way, is just, it doesn't make any sense. I mean, a doctor's job, a doctor's role is to diagnose accurately and prescribe the correct treatment or the correct tests and the correct interventions. So it's imperative to have an accurate diagnosis, and especially with dementia, because there are so many different types of dementia and we treat each one differently.
Okay, so to play devil's advocate, you say there's more than 200-300 types of dementia, correct? Most people have one of, let's say, a couple dozen types. And most people have mixed dementia, which means they have more than one dementia, and nobody really knows for sure how many a person has. So how does all that information, those facts line up against, it doesn't matter what the diagnosis is?
It lines up because once you know and you have an accurate diagnosis, or as accurate as you can get, then you can prescribe the right treatment, the right therapy, the right intervention. Unless you know, if you guess, you might get it wrong, as has happened so many times. I mean, if we think about Lewy body dementia, Lewy body type dementia is very difficult to diagnose. Used to be, maybe 10 years ago, it would be incorrectly diagnosed as Parkinson's disease because the two overlap. You know, Parkinson's and Lewy body dementia very, very similar in presentation, especially in the early stages. So if you diagnose somebody with Parkinson's disease and you treat them for Parkinson's disease when really they've got Lewy body dementia, you're missing the bus, because that Lewy body dementia is just going to get worse and worse and worse. and you're treating somebody for a disease they don't have. So that's why it's absolutely imperative that you do a whole battery of tests to determine as closely as possible what kind of dementia the individual has. And as Lynn said, very often there is mixed dementia. Very often somebody may have Alzheimer's disease and vascular dementia, for example. Parkinson's disease, there is a Parkinsonian type dementia that runs with that. So you have to be as accurate as you possibly can with the right diagnosis in order to use the right treatment and the right therapy. So that's why it's important. That's why it's absolutely vital. It used to be, when I first started out, it was a matter of ruling out everything else because there weren't really all the battery of tests or the knowledge that we have today. So it was about ruling out everything else, everything physical, before you could determine this is probable Alzheimer's disease.
And with new drugs coming on the market that they're trying to use to treat people effectively, isn't it true that some medications are extremely harmful or deadly to people that shouldn't be prescribed to them, even though they could have a form of dementia? Some are not okay for everyone, and some of these new trials and that they're trying with these new drugs aren't okay for everyone.
Right.
And that's why it's crucial also to know that.
Yeah. This segues into, I am studying currently something called the Braidston Protocol. And the Braidston Protocol is all about how you can reverse some of the symptoms of dementia. Now, one of the things in the Braidston Protocol, which has been developed by an MD called Dr. Dale Braidston, and one of the things there is talking about the medication, because no medication to date is able to treat the disease. It can slow down the progression of the disease, but it's not going to cure it. It can treat it to a certain extent, slow down the progression for a while, but it's not going to treat it.
That's any kind of dementia.
And that's any kind of dementia. And it makes a lot of sense because we've got to find the underlying cause of whatever illness, whatever disease an individual has got. And so when you think about dementia and you think about Alzheimer's disease caused by the APOE4 gene, which some people have one and some people have two, which increases your risk of Alzheimer's disease, that's very often related to inflammation. So there's something going on in the body that is causing inflammation of the brain. If you treat that and cure the inflammation, then you will see symptoms of the dementia reversing. So it's a really good question that you asked there, Lynn, because dementia and medication is a very complex issue. And the new monoclonal antibodies, which is given via an infusion every couple of weeks, is aimed at clearing up the neuritic plaque, the beta amyloid plaque in the brain. However, what Braidston is teaching us is that beta amyloid plaque is not the enemy. It's inflammation that is the enemy. So there's a lot to that. But there's with for example, Lewy body type dementia, hallucinations can be really difficult to manage. And the hallucinations tend to be pretty horrendous. And there's only two ways of managing hallucinations, and one is via medication. And if you give an antipsychotic medication to somebody who has Lewy body dementia, it can be very, very detrimental. It can kill. So you have to be very, very careful with that. And of course, the other way of managing that hallucination is by using that word again, validation. yes, I understand that you can see there are snakes on the walls, there are creatures on the floor. So let's go out of the room, let's go into the building, let's go into the garden, have a conversation, let's go out in the car, go and have a coffee at Starbucks, or whatever it is that you can use to remove that person from that experience. Always validating it and never saying, there's nothing there. There is nothing there, because that intensifies the problem and will lead to a conflict. So that was a great question. Thank you for that. Okay.
Well, that's it for today. So,
okay. Well, thank you very much for joining us today. I know that's been educational because the people have asked the questions. So there's obviously issues that people are dealing with out there with that. Any other questions you may have, please feel free to send them to us through Facebook, Instagram, put them on our YouTube channel. And again, I ask you all to share this channel. Share it with your friends, your family, your co-workers, everybody in your circle, because every person I meet knows somebody or is dealing with a cognitive issue. So the more information we get out there, the more accurate it is, the clearer it is, the better for everybody. So get people to subscribe to this channel, get people to follow us on Facebook and on Instagram, and remember, say it with me, dump the soda.